I'm Ethan Argiris, a medical oncologist with expertise in head and neck cancer. I'm a professor of medical oncology at Thomas Jefferson University in Philadelphia. This morning we presented the data from a phase 3 randomized trial in the treatment of squamous cell carcinoma of the head and neck for patients who had recurred or had metastatic disease. We compared a standard treatment with a platinum doublet with the same doublet plus the addition of Bevacizumab, which is an antibody against VEGF. VEGF is very important for angiogenesis, and the combination of chemotherapy and Bevacizumab is approved by the FDA for several other indications. The study accrued a total of 403 patients and looked at the effects on efficacy parameters. The primary endpoint was overall survival, and also looked at the toxicities associated with the addition of Bevacizumab to chemotherapy. We found that the addition of Bevacizumab to chemotherapy improves the response rate and progression-free survival. However, does not improve, at least at a statistically significant level, overall survival, although there was evidence for separation of the survival curves and a numerical advantage for the Bevacizumab arm beyond the first year. Toxicities were increased with Bevacizumab, and there were treatment-related deaths, including bleeding, that mainly occurred in the first 6 months. We think that the toxicity of the regimen and some early deaths may have not allowed for the survival benefit to be seen earlier on. However, the results that we see at 2, 3, and 4 years in terms of overall survival rates as well as progression-free survival rates are very encouraging. And we believe that other agents that target this pathway, the VEGF pathway, warrant study in head and neck cancer. So there are the option of using TKI. There may be problems combining those with chemotherapy, but there are also monoclonal antibodies against VEGF, and those may not be causing as many problems with toxicity, with bleeding. Squamous cell carcinoma of the head and neck may have been associated with more bleeding than other tumors. We know that in lung cancer, the development of Bevacizumab did not continue in squamous cell because of increased bleeding, but on the other hand, it is very active. And it is possible that many patients benefited from the combination of chemotherapy plus Bevacizumab because of various complications, including bleeding, but also other complications, could not receive full therapy. On the other hand, a good number of patients were able to receive planned therapy and continued on Bevacizumab maintenance. And those patients seem to have had a prolonged benefit in their survival from Bevacizumab. I think we need to further analyze this study and look at predictive biomarkers. We need to try to identify why some patients had so prolonged effect from the addition of Bevacizumab, and also analyze more the toxicities and those bleeding events. But I think it points to a direction that the VEGF pathway, it is of potential importance in head and neck cancer. And although the study did not meet its primary endpoint, I believe we can make the argument that further studies need to be done, not necessarily with Bevacizumab, but as I mentioned, with other VEGF inhibitors. Mainly we're thinking of concurrent therapy, but also combinations not with chemotherapy, combinations with immunotherapy may be of interest. No, I think there are many ideas you can build around this, and it is possible that maintenance therapy would be of interest. And perhaps we can explore this in the context of potentially curative disease as well. So I believe showing better response rate, better progression-free survival with an agent other than an EGFR inhibitor is very promising in the field. Suggests that there are other important targets. For the past decade, the only drug and pathway that was of interest was cetuximab and EGFR, but it seems that there are other important targets. We know about the PD-1 and PD-L1 inhibitors, but it's not just that. There are other pathways, and those can be targeted with potentially good results for patients. It was irrespective of HPV status. It was not restricted by any biomarker. However, one of the analyses that we will be doing will include analysis of HPV status. It is possible that patients with HPV do better in the recurrent or metastatic setting as well. We know that they do better in locally advanced disease, but our cooperative group has data suggesting that HPV is a prognostic factor in the recurrent metastatic disease. And it is possible that those patients with HPV-positive tumors have a differential response to targeted agents. That remains to be seen. It is going to be studied as we get the biomarker analysis. We have collected a high number of archival tumor tissue before starting therapy from those patients. And we have collected also a good number of blood samples before and after treatment. I think this is a great material that can be used to further understand why some patients benefited and why some didn't.